this is a very complicated and important question. We know that patients, there's patients with heart failure, obviously, all across America, and many of them are in rural areas where there's smaller clinics. And unfortunately, we know from published data that patients with heart failure in rural areas and smaller areas have worse outcomes. And a part of that may be related to this failure of creating models of care in smaller clinics. So, I mean, I'm not going to act and say that it's easy to do, but there could be an approach to improving how these teams work and become highly productive teams that provide value. And it has to do with several factors. One of them is small clinics need to define roles. Everybody needs to work at the top of their license. So whether it's a PCP or cardiologist, they need to identify nurses that work at top of license, pharmacists that work at top of license, and they need to collaborate together. So I think that's one element, defining roles. Another one is adopting protocols. There's no secret about what these protocols are. They're published in the guidelines, and they're widely available. I mean, clinics can create a shared, a one-page plan that has, what are the target medications for patients with heart failure? What's the titration schedule? What's the plan for drawing labs? If people develop fluid overload, there needs to be a diuretic algorithm. There needs to be thresholds for escalations. Honestly, a lot of these things can be summarized on one page. And when you put things on one page, it's easier to remember and to follow. I think that another element that could help smaller clinics succeed is having touch points with a specialist. So Dr. Kadosh and I are advanced heart failure specialists, and within our respective healthcare systems, we back up various other teams, and that can happen through e-consults or through a intermittent case conference, an email, a phone call. It doesn't have to happen every day. It could, but usually most of the time, that's not needed. But having a specialist in the background could help and give people confidence. And then the last thing I'm going to add is identifying community resources. So we know that patients with heart failure greatly benefit from cardiac rehab. So aligning with a cardiac rehab center and also with the dietitians could potentially provide extra value in creating this high-performing team.
Yeah, and I would just add to that we need to demystify heart failure treatment. And you don't really need an advanced heart failure physician to treat most patients with heart failure. I think we are here to kind of lift up the patient when they get to the stage where they may need a little bit more help than what GDMT is able to provide for them. We're here for support, and we can always be here for education and for remote consults, as Dr. Gorodeski mentioned. I think that most of the workforce in the United States that will be touching a heart failure patient will probably be internists, primary care physicians, general cardiologists. Advanced heart failure is really limited to major centers with capability for transplant and LVAD. And so I think it's incumbent upon us to make it easier and more accessible to titrate these therapies and to say, listen, it's not that complicated. If a bariatric clinic can titrate the GLP-1, then we can titrate our beta blockers and our ARNIs. It can be done, and it can be done really efficiently, quickly, and safely.
And we have another real-world problem that Dr. Kadosh was kind of implying without saying it, is that, but I'm going to say it out loud, we have a workforce crisis in the field of advanced heart failure. What we've been seeing over the last few years is that fewer and fewer cardiology fellow graduates are choosing to go into our field. And right now we have, depending on the year, somewhere between 60 and 70 some cardiology fellows who choose to go into advanced heart failure and transplant cardiology training. And if you think about the epidemic of heart failure in the United States and how many millions of patients there are, anybody out there listening who thinks that there's going to be a heart failure doctor to help everywhere, unfortunately, it's impossible. The numbers just are not there. There's not enough subspecialists. A lot of times people like us are going to be within larger healthcare systems and dealing with advanced heart failure therapies like transplantation or LVAD. Um, so it's, the health systems of the United States really need to improve without waiting for us. I mean, we're always going to be there for backup, but there's just simply not enough of us. Um, Luckily, we have very clear guidelines and things that can be implemented, that are not a secret to provide care, and they need to happen. Again, the heart failure epidemic is just getting worse. It's predicted the numbers are predicted to continue to grow. So this is a very timely and important conversation.
Well, I think we do need to recognize that pill burden is an issue. And when I see patients with heart failure de novo in my clinic, where I'm going to be starting a lot of medications, I start off by saying, look, there are 4 medications that pretty much every heart failure patient should be on, and we're going to try and get you on all 4, and they work together in this way. And I spend time with the patient so that they understand the mechanism of action of each of those drugs and that they understand why I'm doing what I'm doing. So it's not just, you need to take this, you need to take that. And I do think that helps with acceptance. The other thing that's helpful is that these drugs are going generic. So sacubitril valsartan just recently went generic. Dapagliflozin is a generic SGLT2. The other drugs have been generic for years. That does help with costs. In the past, cost has been a major issue. It's still not completely resolved with this. Even the generics can be expensive for some patients. But again, this goes back to concentrating efforts on the medications that change the trajectory and make the patient feel better. A lot of patients come to me on diuretics, and it just so happens that if you treat a heart failure patient really well and you get them on all the therapies at target doses, a lot of those patients don't need diuretics anymore. That's another pill off the list. And so it goes, and there are supplements and other things that are not necessarily evidence-based, and so we can discuss those and try and reduce the pill burden. But I think it is important to recognize that it's an issue.
It's so interesting how so many patients come to our clinics. We were just talking about this before, and they're willing to take all types of supplements and vitamins and all other extra pills. And then you tell them, well, you need to be on 4 medications for heart failure. And their eyes are, they're wide open and they're shocked. And it's so many pills. And it's just the paradox of practicing medicine in the United States in 2026. And we all have to deal with it. What can we do? I mean, first of all, we need to acknowledge the pill burden, and we know that patients feel it. And I think that for us as physicians to ignore the pill burden will fuel distrust. So we need to acknowledge, and we need to say up front, what I'm about to tell you is a lot. It takes a lot of therapies to take care of heart failure. And then I think that the next step is to explain why these therapies are life-saving. All the class 1 recommended drugs for, especially for HFrEF are life-saving. And I think that that's what we need to emphasize. These medications reduce the risk of getting hospitalized or hospitalized again. They may help the structure of the heart improve, the function of the heart improve, and they improve survival. So hopefully by hitting on those points that are obviously very important to every single patient, it builds trust.
As an advanced heart failure physician, I spend a lot of time thinking about patients who are worsening with heart failure. I think a lot about patients who are not just stage C or stage D, but in between, the stage C2D patients, those ones that are sliding towards end stage. And the current in the current paradigm, a lot of the national registries and databases really only capture stage D patients that are being referred for heart transplantation, LVAD, or palliative care. And, there's a subset of stage C patients that are worsening, those patients who are on medical therapy for heart failure, but continue to be hospitalized, continue to worsen, continue to have comorbid conditions related to their heart failure worsening, and they're not necessarily captured. And so we don't really have a good idea of the incidence and prevalence of those patients. And I think if we made it a little bit easier to capture who those patients are, where they are, those were the patients that would benefit greatly from early referral to an advanced heart failure physician. And I think that is a huge gap that really needs to be filled.
To me, I think that future research needs to focus on that implementation gap that we spoke about before. We have a ton of therapies that are outstanding and improve outcomes, but we also see at the same time that many patients are not on them. And it's that implementation gap that needs to be overcome. And we need to understand how to overcome it, especially in a world where there's not many heart failure doctors, there's not enough cardiologists. Only 1 out of every 2 counties in the United States has a cardiologist. I'm not even talking about a heart failure cardiologist. I'm talking about a cardiologist in general, which is pretty shocking. But yet at the same time, we're really entering an incredibly exciting phase of human history with artificial intelligence. And we've all started playing with it in our own worlds. And it's eye-opening, and you kind of wonder, is there a future where AI can help us overcome the implementation gap for GDMT, whether it's through education of patients, whether it's through helping develop and make sure that pathways are being followed. They start in the hospital with the EMR, and then they continue home on smartphones and tablets. So there's a lot there, which is really exciting. It's going to force us to think differently, and I'm looking forward to it. I'm excited.
And going back to what you said about the accelerating and decelerating risk, I mean, that is something where implementation of AI with all of the information that's available in the chart could be very useful. Just flagging patients who are accelerating risk and who need to be referred, I think would be like a really amazing development.